Good afternoon, everyone. So today my talk is on leptospirosis, challenges in diagnosis. So as a microbiologist, I thought of talking a little bit about the microbiology regarding the leptospirosis. So leptospirosis is a zoonotic disease which is caused by pathogenic Leptospira species. The Leptospira is a spirochete bacterium. It is a highly motile obligate aerobe. And although it says that it's a gram-negative bacterium, it is rarely seen by this gram staining. So it's best to be by dark ground microscopy. So very important, it is killed by desiccation, extreme pH, 70% ethanol, autoclaving, pasteurization, and low concentrations of chlorine. So this would be important for the prevention. So transmission is by direct inoculation with infected animal tissue or body fluids, or indirect via mucosal surfaces or damaged skin. And there are cases of person-to-person transmission, but it is rare. So this slide is very important. Slide gives you insight about how to the investigations and what samples that you would need to take according to the natural history or the disease progression. So as you all can see, so the first week, the Leptospira can see in the blood from the mid first week to mid of the second week, they would be there in the CSF. From the second week onward, the Leptospira will be up to 2 to 4 weeks would be in the urine. So second week onwards, because of the immunity, so Leptospira will cleared from the body, mainly the blood and the CSF, and the immune reaction will occur and immunoglobulins will appear. So this is very important. So according to the disease progression, you have to decide on what sample and what test you are going to do. So as you can see, at the initial part of the disease, the Leptospira level is very high, but with the immunity, the number of Leptospira will go down. So moving on to the diagnosis. So there are these case definitions. Most of them are surveillance definition, but we can get an idea how to use this surveillance definition into the clinical practice. So usually a suspected case is a case coming with the signs and symptoms and an epidemiological link, and probable case when it is when the immunoglobulins are detected by the ELISA. It's not confirmed, that's a probable case. And confirmed case, a suspected case which is confirmed by seroconversion of fourfold ricin MAT, or detection of Leptospira in clinical specimen, or demonstration of Leptospira in tissue. So when would clinician consider the diagnosis of leptospirosis? Any patient presenting with an abrupt onset of fever, chills, conjunctival suffusion, headache, myalgia, and jaundice. As we are an endemic country, when a patient is coming with these symptoms, you have to think, is this a case of leptospirosis? So the suspicion is increased when there is a history of occupational or recreational exposure to infected animal or environment potentially contaminated with animal urine. So the most distinguished physical findings are conjunctival suffusion, muscle tenderness, most notably in the calf and the lumbar areas. So why clinical diagnosis is challenging? It is difficult and has limited reliability. Why? Most of the symptoms are non-specific and they're variable according to the presentation. And they could easily classified as other febrile illnesses. So in our part of the country, in Sri Lanka, so dengue is endemic. So we can misdiagnose leptospirosis as dengue because in the early part of the presentation, it would be difficult to differentiate. So low sensitivity and specificity of clinical diagnosis. Sometimes only cases with severe disease and those exhibiting a classical presentation will be diagnosed clinically. So moving on to the laboratory diagnosis, there are non-specific laboratory findings. They are supportive but not confirmatory. So in blood analysis, there would be leukocytosis when compared to the dengue, and thrombocytopenia, and elevated ESR, blood urea, AST, ALT, bilirubin, and alkaline phosphatics. So So urine analysis, so you would be seeing these changes. So these are only supportive, but for the confirmation, you have to go for the microbiological diagnosis. So the microscopy, as I said earlier also, you have to use the dark ground microscopy or the phase contrast microscopy. Samples, blood, CSF, urine. So you have to take the samples in the early part of the disease. Highest yield is in the first week of the illness. So advantages are we can use them for the observation of Leptospira in culture and observing agglutination in mat. Disadvantages, you can't use this for the acute diagnosis and for the clinical diagnosis, and interpretation is subjective, technically demanding, and proteins and other fibers in the samples are easily confused for spirochetes. And the other thing is you can't differentiate Leptospira from the other spirochetes and even from the non-pathogenic Leptospira. So culture is the definitive diagnosis. Samples are blood within the first 10 days before antibiotic and urine from the second week. For the blood cultures, there are specific culture medias, LMJH media. So you have to inoculate directly at the bedside into these culture bottles to yield a highest yield. And the other thing is cultures need to be kept for 13 weeks before negative report can be given. So advantages, that is the strongest evidence for confirmation, and we can use that in MAT, can perform antibiotic susceptibility testing, and importantly, isolated Leptospira can be typed to identify serovars. That is epidemiologically very important. So the typing of the isolates is needed for the surveillance of the local pathogenic serovars, recognition of new patterns of the disease presentation, assessing the effectiveness of intervention measures. So we can't use cultures for the acute diagnosis because it is taking so much time. The Leptospira has a very longer generation time, 6 to 8 weeks. So cultures do take a lot of time and the low sensitivity. So the serology, we all know this microscopic agglutination test, MAT. So that's the serological reference test. Cutoff values are determined by the seroprevalence. So we can confirm by if there is a titer of more than or equal 1 into 320 or 4-fold rise in paired sera. So for the paired sera, you have to take 2 samples. First sample after the first days of illness. You have to remember that slide. So see, serum sample you have to take after the first week when the antibodies are going up. So the second sample 10 to 14 days after the first sample. Highly specificity with paired sera is the advantage, but unfortunately we can't use this for the acute diagnosis. And we have to maintain the live Leptospira, and it's time consuming and technically demanding, and sometimes antibodies may not be detectable when the positive strain is not represented in the panel. There's a panel, there are a number of serovars, but sometimes we may miss the newer serovars. So ELISA, there are ELISA kits to diagnose leptospirosis. It is a screening test. So we can use that for the early presumptive diagnosis, but you need to confirm. So you have to send the serum after 5th day of illness. Rapid diagnostic tests are there. Mostly they are at the research level. So they are insensitive for the diagnosis within first week, inferior to the empiric therapy, although they are easy to perform and no special training is needed. Molecular testing, which is very important. We can do real-time PCR. So the samples are the blood within 7 days of illness, CSF within 10 days of illness. So this is very useful for the acute diagnosis and highly sensitive and specific. Disadvantages need specialized equipment and dedicated laboratory space and highly skilled personnel. And other thing is, because of the contamination, it can give false positive results. So the take-home message is, as we are an endemic country, you need to have a high clinical suspicion for early diagnosis and appropriate sampling and testing according to the natural history of the disease is mandatory for the confirmation of the leptospirosis. Need of the hour. We need to have highly sensitive and specific rapid diagnostic tests for the early diagnosis. So we can treat the patient properly without going them into the immunological consequences. So these are my references. Thank you. And it's good to be back to where I began my career. And I would like to pay gratitude to all my teachers and the academic and non-academic staff at Faculty of Medicine Allied Sciences, Rajarata University. Thank you.